Good morning. Luckily, it was not the last couple of years. It's only 2022, 23, because this field is expanding. And really, to look at the literature over the last 2 years, there are so many things. And forgive me, Dr. Kabadia, because we don't have the device in here. I'm not going to present the trial that you led for the valve. So I decided to go over the platform for the valve, but in order to keep it focused to our region, I tried to review the data for the current available devices for us in the Middle East. So as you can see, this is courtesy of Dr. Azim Latif. The field of tricuspid valve is really expanding between annuloplasty, coaptation, enhancement devices, the orthotopic replacement devices. Currently, we have the EVOKE and the interbreeding clinical trial. Also, there is the Navigate led by Dr. Kabadia and so many other also valves. The heterotropic replacement, which is the trick valve currently available. So in order to keep it focused within the limited time, we're going to discuss trials related to the devices that's available to us. The first one is basically the tri-clip. It's a modification of the mitral clip device with some steering capability that allows for steering within the tricuspid alley. This trial specifically was a visibility trial and effectiveness, and limited number of patients, around 62, high risk for intervention. All the theme for the subsequent trial, patient has to be intermediate to high risk for tricuspid valve intervention. The entry of the trial has to be at least moderate tricuspid valve regurg. Patient, if they have severe pulmonary hypertension, they were excluded, or if they have a previous tricuspid valve. Also, if they have a coaptation gap more than 10 millimeter because of the use of the device. This trial clearly showed effectiveness of the device in reducing the mitral regurg. If you look at the baseline compared to a 20-year, 71% reduction in 30 days, 71% reduction of the MR to moderate and less. More importantly, when you look at this device, this reduction is sustained up to 1 year. When you look at 1 year results, still 70% of the patient enrolled having MR less than moderate. The device is safe. Overall, major adverse event was around 7.1% at 1 year. This also recently came in the PCR slide courtesy to the Philip Rose. This just accepted to Jack, so sorry I did not bring the slides from Jack. But in general, this the reason that I presented this is as an introduction to the only randomized trial currently we have in the tricuspid alley. Basically, the BRIGHT trial was investigator-led, mainly European center, looking at the safety of the tri-clip for tricuspid regurg. Same almost inclusion criteria, some exclusion in relation to severe pulmonary hypertension, and if you have a significant left-sided valve that was left untreated. At 1 year, out of the 200 patients, again, the cardiovascular mortality was around the major adverse event was 11.5%. The single leaflet detachment was around 3% in this trial. As far as effectiveness of the device, clearly it has demonstrated a significant reduction in the grade of the TR, with 88% of the patient has moderate and less tricuspid regurg. Corresponding to this also is a good measure. This trial also showed us some good RV remodeling with the device. If you look at the tricuspid annular diameter and also the RV end-diastolic diameter, both showed favorable result at 1 year with the edge-to-edge repair. The reduction of the TR corresponds clearly to an improvement in the New York Heart Association at 1 year, with 77% of the patient were at class 1 to class 2 versus only 21% at the entry of the trial. The quality of life improvement clearly was significantly favoring the device at 1 year, and also when they analyze this based on the degree of TR reduction, it corresponds nicely to the TR reduction. So far, 2 trials, not randomized, clearly showed improved benefits of the device for reduction of TR. Now, the transilluminate pivotal is basically the only currently randomized trial that tested the edge-to-edge technology compared to medical therapy. Basically, the trial was testing safety and effectiveness of tricuspid valve repair system, the same device, which is the TriClip, in order to reduce TR. The inclusion criteria, similar to the previous trial, guideline-directed therapy was mainly diuretics, and patients who do have more or any left-sided valve lesion were excluded. Patients with severe pulmonary hypertension, patients who have LV dysfunction was also excluded. What is peculiar about this trial, they have a steering committee specifically related to assessing the anatomical suitability for all candidates before randomization, and I think that was clearly very evident in this trial. Now, the primary outcome was looking at a composite endpoint, including mortality, heart failure admission, the quality of life improvement, and the degree of TR reduction. And there is also a peculiar way of looking at this. They looked at something called the win ratio, which is basically a cumulative event related to each of those events. The baseline characteristics of the patient were similar to the previous cohort that you saw in the previous two trials. There is at least 50% of the patient had torrential TR. The RV dimension were very comparable between the two groups with no major differences. One point of note when you look at the result, this trial was in 2019 till 2021, during which time was also the COVID. So that also, when the trial came, was one of the arguments about the heart failure admission. Could people stay more at their home because of COVID? Now, the reduction of the TR was clearly evidenced with the device, with 87% of the patient in the device arm achieved less than moderate TR. This also, as the previous trials, was sustained throughout the whole 1 year of the follow-up. When you look at the primary endpoint, which is again using the win ratio, a composite of mortality, heart failure, and the quality of life, there is a clear difference favoring the device, mainly driven by the quality of life improvement. There is no difference in terms of death, tricuspid valve intervention, or even heart failure hospitalization. The heart failure hospitalization, as I said, was a quite, I won't say, probably it was a surprise. You would have expected an improvement in heart failure hospitalization, but one of the arguments was the timing of this trial was during COVID. The device, as has been shown in the previous studies, is safe. The overall adverse event was really low, and basically the risk, there was the bleeding, but the slight higher risk of single leaflet detachment compared to the previous trial of nearly 7%. So no difference in terms of mortality of tricuspid valve or the need for tricuspid valve surgery. No major difference in heart failure. Clear, meaningful difference in the quality of life also correspond in the similar previous trial to the degree of reduction of the tricuspid valve. So overall, the trial was positive in terms of achieving outcome, which was the reduction or the improvement in symptoms. The second device that I'm gonna just quickly discuss which is also available, is the Pascal and Pascal Ace. And basically, there is currently ongoing randomized trial in the US. Here we are presenting just the CLASP TR, which is basically a single arm trial that looked at the safety and effectiveness of the device in a similar design to the previous trial, where you looked at the amount of TR reduction. The device was very effective in reducing TR. Nearly 80% of the patient at 1 year sustained the reduction of the TR to less than moderate. Also, this has been associated with a clear improvement in the quality of life. In terms of device safety in the initial trial, the success of the implant was 91%. There was certain definition in this trial in terms of success of the implant, success of the procedure, but overall the success of the device, meaning inserting the device, getting out of the delivery system, was very high in this device, which is around 91%. This also just came out recently from the Class 2 trial, which basically for each center, which is going to...
1 minute, please.
1 minute. So for each center which is going to randomize in the Class 2 trial, they basically analyze the 3 roll-in patient. May I have...
Can we get the slides? Yeah.
Yeah. So basically, this is analysis of those 3 roll-in patient.
Next slide, please.
Similar population to what we have seen in the previous trial in terms of tricuspid valve, almost 50% has severe, and 20% had torrential TR. The success of the implant in this roll-in basically reflect the experience of the center. It's their first 3 roll-in patients, around 84%. The result was as similar to the previous trial, nearly 73% reduction in the TR, and this was a core valve adjudicated result, core lab adjudicated result. This also corresponds to an improvement in the symptoms with the New York Heart Association of nearly 86% of the patients achieving Class 1 to Class 2. What's also good in this trial, which has been reported early, is as we've seen in the previous trial, a nice evidence of RV, or good RV modeling using the echo. I'm going to skip through this because I think it's important to show the trial clip. This is basically the TRISCEND trial. But the last one I'm going to present to you is the trick valve, because also it's available. This is the visibility trial, basically of 6 months, mainly in Europe, severe TR, inoptimal medical therapy, New York Heart Association Class 3 or 4, significant backflow of the IVC to the IVC or the SVC, a V wave of more than 25. Patients were excluded if they have severe pulmonary hypertension, a TAB-C less than 13. Basically, a more severe degree of also TR compared to the other trials. The device is basically two valves, one in the SVC and one in the IVC. I think you calculated the time from the original start. I didn't finish 10 minutes. So basically, the device showed a very nice success in terms of deployment, 97%, an effective reduction in the symptoms. There is no assessment of TR because this device basically isolates the right atrium, and basically clearly there is an improvement in symptoms. My read in the tricuspid valve literature, so far, we are treating the tricuspid valve as we look at the left-sided valve, and we want the similar outcome, but this is a very slow progressive disease. The current trials so far focus on safety and effective delivery of the device, also clearly have shown an improvement in symptoms. Whether this translates into mortality in the future, probably if we randomize the number of patients that is needed and maybe early on in the disease process. Probably what I have seen in this trial is an aggregate of predictors that help us in the future to select the best patient that will drive benefit. We probably would know about the role of early intervention in tricuspid valve maybe in the future based on the result of those trials. What I've seen so far is a clear, safe procedure in terms of delivery of transcatheter valve, and even the edge-to-edge repair all have a more than 90% success rate and a very low procedure complication. Thank you.